Welcome back to Anatomy and Physiology 2 at Wayne County Community College. Today we're going to discuss the urinary system, Chapter 42 from our patent textbook. This video is going to cover the gross anatomy of the urinary system. Before we meet next time, I'd recommend that you review this very fine video from Betty Smith, RN, which goes over the blood flow through the kidney, as we will be discussing the formation of urine and the blood flow through the nephron. The urinary system doesn't just produce urine. It takes the blood that flows into the kidney and it will remove the organic waste from all the body fluids. It will also discharge those waste products, which are mainly urea, uric acid, and creatinine. The urinary system will also adjust the water content so that the body does not have too much or too little water to maintain the constancy of the internal environment. Thus, in controlling the blood plasma volume, it also controls the blood pressure. The urinary system also controls the important ions such as sodium and potassium and adjusts them to match set point levels. As well, the blood pH can be altered to match set point levels. In these ways, the urinary system regulates the content of the blood plasma to maintain homeostasis, or dynamic constancy of the internal fluid environment, which is maintained within normal limits. The principal organs of the urinary system are the kidneys, which process blood and form urine as a waste product to be excreted. On a gross macroscopic level, the kidney has three main layers: the parenchyma, which includes the renal cortex underlying the surface of the kidney, and the renal medulla in the center. There is also the renal pelvis, which is an area for collecting the urine. Here you see the main organs of the urinary system depicted. You have the kidneys, which are supplied with blood from the aorta and will return blood back to the heart through the inferior vena cava. The kidney will be drained of its urine, which will be taken away through the ureters, which extend from the kidney down through the abdominal cavity and into the pelvis. The ureters unite there with the urinary bladder, which is the temporary holding or storage area for the urine, and the urine is then excreted to the outside of the body through the urethra, which is longer in men and shorter in women. The kidneys are about fist-sized, and they are our classic retroperitoneal organ, meaning that they are posterior to the parietal peritoneum against the posterior wall of the abdomen. They measure about 11 centimeters by 7 centimeters by 3 centimeters in size, the left kidney being often larger than the right. They are located on either side of the vertebral column and extend from the level of the last thoracic vertebra, T12, to just above the third lumbar vertebrae. And generally, as depicted in letter B, the upper picture, the left kidney lies superior to the right kidney. In C, you will see that the kidney is surrounded by a renal fat pad. This is a heavy cushion of fat that surrounds and protects each kidney. Each kidney has a tough, fibrous covering that is adherent to it. This is the renal capsule, and it is rich in pain receptors, which are called nociceptors. As well, there is renal fascia that anchors the kidney to its surrounding structures. The medial surface of each kidney has an indentation called the hilum. This is where the renal arteries enter the kidney, the renal veins exit, as does the ureter. Here is a medical illustration of a coronal section of the right kidney. The basic organization of the kidney is depicted. You'll see the fibrous capsule that is adherent to the cortex of the kidney. Underlying the cortex will be the renal medulla. Then you will find the minor calyces, which join to form the major calyces, which unite and form the renal pelvis, where the urine collects and then will leave through the ureter out of the hilum of the kidney. Here you see a preserved human specimen of a right kidney that you can compare to the artist's rendering. Let's go through the major structures of the kidney, beginning with the hilum, which is the concave notch through which the renal blood vessels and other structures enter or leave the kidney. The renal cortex is a superficial portion of the kidney that's in contact with the renal capsule. The renal pyramids lie underneath and abut against the renal cortex. Approximately 6 to 18 of these conical or triangular structures would be a normal amount. The renal pyramids make up the bulk of the medullary tissue. The base of each pyramid faces outward, and the narrow papilla of each faces toward the hilum. You can see that within the pyramids there are parallel columnar structures that we'll discuss when we're discussing the making of the urine. Each renal papilla has multiple openings that release urine. Note that the cortical tissue dips into the medulla between the pyramids, forming areas known as renal columns that we'll see on our next collection of slides. Right here you see that the renal cortex I've highlighted in yellow. And on this slide, you see that I have outlined a renal pyramid in green. The renal column. These are bands of cortical tissue that dive down between the pyramids and separate the adjacent renal pyramids from each other. They extend into the medulla and they have a distinct granular texture. Let's look at these in the next picture. So these are the renal columns that you can see are contiguous with the renal cortex. And as I said, they dive down in between each pyramid. The renal sinus is an internal cavity within the kidney, and it's lined by the fibrous renal capsule. The renal sinus is occupied by the renal pelvis, renal calyces, blood vessels, nerves, and fat. The renal hilum extends into a large cavity within the kidney, occupied by renal vessels, minor renal calyces, major renal calyces, the renal pelvis, and some adipose tissue. The renal lobe is a portion of a kidney consisting of a renal pyramid and the cortex above it and the adjacent tissues of cortex that dips down on each side, or the renal columns. This is the unit of the kidney that produces the urine. The renal papilla is the location where the renal pyramids in the medulla empty urine into the minor calyx in the kidney. Histologically, the renal papilla is marked by medullary collecting ducts that converge to form a papillary duct to channel the fluid, or urine. Transitional epithelium begins to be seen here. Transitional epithelium is a type of stratified epithelium. This tissue consists of multiple layers of epithelial cells which can contract and expand in order to adapt to the degree of distension needed. Transitional epithelium lines the organs of the urinary system, and it is often known as urothelium. A renal papilla will have multiple openings that release urine into a minor calyx, and multiple minor calyces will unite to form a major calyx. These are the cup-like structures that you will see at the ends of each renal papilla that collects the urine. The major calyx will then funnel urine into the renal pelvis. In humans, the renal pelvis is the point where the 2 or 3 major calyces join together. It has a mucous membrane and is covered with transitional epithelium and an underlying lamina propria of loose to dense connective tissue. The renal pelvis functions as a funnel for urine flowing to the ureter. And the functional unit of the kidney where the urine will ultimately be formed is the nephron. And we will discuss this in greater detail in our next lecture. But just so you know, the nephron is the microscopic structure and functional unit of the kidney. It is composed of a renal corpuscle and a renal tubule. Not too meaningful to you at this point. This is where the urine or the blood will come in, and urine production begins as fluid is filtered out of the blood in the renal corpuscle. So let's look at how the blood supply comes into the kidney. The kidneys are highly vascular organs, receiving about a quarter of the total cardiac output. About 1,200 milliliters of oxygenated blood flows through the kidneys each minute. This blood comes in through the renal artery, which is a large branch off of the abdominal aorta. As it nears the kidney, the renal artery divides into segmental arteries. It is the segmental arteries that pierce through the hilum, and then they will divide into lobar arteries, each of which enters the kidney substance through or near a renal papilla. Each lobar artery then gives off 2 or 3 branches called interlobar arteries, and these will run outward between the adjacent renal pyramids toward the cortex. There they will arch over the bases of the pyramids to form arcuate arteries. From the arcuate arteries, interlobular arteries will penetrate the cortex. Because they are penetrating the cortex, they are also called cortical radiate arteries. And I recommend that you learn to differentiate your interlobar arteries from your interlobular arteries, because that is always highly tested and highly tricky. The interlobular arteries are given off at right angles from the side of the arcuate arteries. They then pass directly outward between the medullary rays to reach the fibrous tunic. Here, they will give off lateral branches, which are the afferent arterioles that will supply the renal corpuscles of the nephron. The afferent arterioles branch from each interlobular artery or cortical radiate artery, and they enter Bowman's capsule. Here they will deliver blood to the capillaries that supply the renal corpuscles of the nephron and end in the glomerulus. We will examine the nephron much more closely in the next lecture. Let's review the renal blood flow into the kidney. The renal artery carries oxygenated blood into the kidney. It comes directly off of the aorta. The renal artery then branches into the segmental arteries, which pierce into the kidney through the hilum. The segmental arteries then divide to become the lobar arteries. Between the pyramids of the kidney's medulla, the lobar arteries branch to form the interlobar arteries that extend outward toward the cortex and then arch over the bases of the pyramids to form the arcuate arteries. From the arcuate arteries, interlobular arteries or cortical radiate arteries penetrate the cortex. From these, we will get the afferent arterioles that will carry blood directly to the tiny functional units of the kidney called the nephron. Picture A is an artist's rendering of the circulation of the kidney, and it shows the major arteries and veins of the renal circulation. We haven't yet discussed the veins, but they correspond to the arteries and are named accordingly. Picture B is a renal arteriogram. You can see that at number 6 is where the tip of the catheter is entered into the renal artery. At number 5, we have the main renal artery bringing the oxygenated blood into the kidney, where it branches into 4, a segmental artery, which then branches into 3, a lobular artery. From there, the lobular artery branches into number 2, the interlobar arteries, which extend and go around the renal pyramids. and then arch up to form number 1, the arcuate arteries that arch over into the cortex area surrounding the renal pyramid. Let's now examine the urinary tract. Here you see the kidneys at the level of T12 underneath the rib cage, and from that extends the ureter, which is approximately 30 centimeters in length, and the ureter will then course through the retroperitoneal area of the abdominal cavity, and then it courses into the pelvis until it reaches the bladder, where it attaches to the bottom of the bladder. Here in the female on the left, you can see the ureters are in close proximity to the ovaries and cervix of the uterus. The bladder lies anterior to the uterus and the vagina. As many of you know, when we want to ultrasound the developing fetus in the uterus, we ask you to drink an extraordinary amount of water to overfill the bladder and raise it up above the uterus so that we can get a good ultrasound view of the developing fetus. Of course, all that water in your bladder and then compressing on it with the ultrasound wand is not very much fun for most women. In the male urethra, you can see it extends much longer than the female urethra. The female urethra is about 3 centimeters long, and the male urethra is about 20 centimeters long. The male urethra passes through the center of the prostate gland just after leaving the bladder. Thus, you can see why in men, when the prostate grows in older ages, when men frequently develop benign prostatic hyperplasia, how the prostate gland can encroach on the lumen of the urethra and cause some difficulty with urination. Within the prostate, the ureter is joined by 2 ejaculatory ducts. After leaving the prostate, the urethra extends down, forward, and then up to enter the base of the penis. Here, it travels through the center of the penis and ends as a urinary meatus at the tip of the penis. Because the male urethra is joined by the ejaculatory ducts, it serves as a pathway for semen as it is ejaculated out of the body through the penis. Therefore, the ureter is both part of the urinary system and part of the male reproductive system. The urine is prevented from mixing with the semen during ejaculation by a reflex closure of the sphincter muscles guarding the bladder's opening. Let's see another view of the urinary tract. Here we have an intravenous pyelogram, also known as an IVP. To do a pyelogram, you inject a contrast material through a vein, and then it travels through the blood and makes its way to the kidney, where the contrast agent is picked up on an X-ray. And here we can see the contrast agent in the minor calyces and major calyces and in the renal pelvis, and traveling on down through the ureters to the bladder. And IVP can show things like a blockage by a kidney stone. It can show enlarged prostates, kidney cysts, urinary tract tumors, narrowing or strictures of the ureters, different defects. It is very useful without being very invasive. Here is a cross-section or transverse section through a ureter. We have our protective mucosa, which is comprised of our transitional epithelium overlying a thick fibroelastic lamina propria. Observe the thick layer of smooth muscle outside of the mucosa, which will function to move the urine by peristalsis through the ureter and bladder. And there is an outer adventitial layer that has fibroelastic connective tissue that contains blood vessels, lymphatics, and nerves. This is contiguous with the From our paired kidneys, we have the bilateral ureters that are thin, 3 to 4 millimeter wide tubular structures. that are about 30 centimeters long and extend to the urinary bladder, where they will transport urine from the renal pelvis to the bladder. As they arise from the kidneys, the ureters are retroperitoneal. Here, the ureteral openings will be slit-like rather than rounded, and this shape helps prevent backflow or reflux of urine when the urinary bladder contracts. The ureters function to propel urine distally to the bladder through peristalsis. Let's examine the ureters further. Here is a beautiful photograph of the ureters, which are encircled by yellow vessel loops. Here you see that the ureter is a The ureter descends on the psoas major, and then it crosses to the bifurcation of the common iliac artery, coursing along the lateral wall of the pelvis before it turns medially to reach the posterior surface of the bladder. Note also the positions of the aorta and the inferior vena cava relative to the structures of the urinary system. Now let's look at the ureter as it enters the coronal section of the bladder. Here you can see that the ureter enters the bladder wall obliquely and is covered a little bit by a mucosal flap, the vesicoureteral valve, which is an important structure because it normally prevents the reflux of urine from the bladder back into the ureter and renal pelvis. And on the next slide, we have another ureter cross section. Here we can examine the many folds of the mucus lining that unfold to permit the stretching as the urine passes through the tube. The nature of transitional epithelium allows further stretch without damage to the mucosa. A thick muscular layer of smooth muscle helps pump urine toward the bladder. On its outer surface, the ureter is covered by a tough, fibrous connective tissue coat. Let us now move on to examine the structures involved in urine transport, storage, and elimination. The cup-like calyces are considered the beginning of the plumbing portion of the urinary system, for it is here that the urine leaving the renal papilla is collected for transport out of the body. The cups that drain the papilla directly are the minor calyces, and these will coalesce to form the major calyces. The major calyces join together to form a large collection basin, which is called the renal pelvis. The pelvis of the kidney narrows as it exits the hilum to become the ureter. All of these are lined by transitional epithelium, which undergoes cycles of distension and contraction. The ureter has peristaltic contractions that will begin at the renal pelvis and sweep along the entire ureter. This will force urine toward the urinary bladder in peristaltic waves that occur every 30 seconds. The urine will be expelled from the urinary bladder to the outside world. The urinary bladder is a hollow muscular organ that functions as a temporary reservoir for the storage of urine. The typical human bladder will hold between 300 and 500 milliliter of urine before having the urge to empty occurs, but it can hold considerably more, up to about 1 liter of urine. The Latin phrase for urinary bladder is vesica urinaria, and the term vesica or vesicle or the prefix vesico will appear in connection with associated structures of the bladder, such as the vesical veins. The modern Latin word for bladder, cystis, appears in association with terms such as cystitis for inflammation of the bladder or the infection of the bladder. The bladder is stabilized in position by several peritoneal folds that form ligamentous bands, which will anchor the urinary bladder to pelvic and pubic bones. Let's examine this. Here is a picture of the urinary bladder in the male. The urinary bladder has 4 main regions. The fundus or base is the postero-inferior part of the bladder. The body is the large area situated between the apex and the fundus, and the neck of the bladder is the constricted part of the bladder that leads to the urethra. So the four areas are the fundus, the body, the apex, and the neck. The apex is directed toward the upper part of the pubic symphysis, and from there, the median umbilical ligament continues upward on the back of the anterior abdominal wall to the umbilicus. The peritoneum is carried by it from the apex to the abdominal wall to form the middle umbilical fold. The neck of the bladder is the area at the base of the trigone that surrounds the internal urethral orifice that leads to the urethra. In males, the neck of the urinary bladder is adjacent to the prostate gland. The two ureteral openings and the orifice of the internal urethral sphincter mark the triangular area that forms the trigone of the bladder. These openings enter the trigone obliquely, and they also have mucosal flaps in front of them that act as valves in preventing the backflow of urine or urinary reflux into the ureters. The trigone is a smooth muscle area that forms the floor of the bladder above the urethra. It is an area of smooth tissue for the easy flow of urine into the urethra. This is in contrast to the irregular surface formed by the rugae that you see depicted above the trigone. In men, the prostate gland lies outside the opening for the urethra, as depicted here, and this is often a lab practical exam question. If you are shown a bladder, you might be asked, does this bladder belong to the male or the female? And you should be able to tell the male because the prostate gland is right below the neck of the bladder and it surrounds the prostatic urethra, whereas the prostate gland is not present in the female. The inner walls of the bladder have a series of ridges of thick mucosal folds that are known as rugae that allow for the expansion of the bladder, and these will disappear. This is in contrast to the trigone of the bladder, which is a smooth area for easy flow that directs urine into the urethra. The trigone is bounded by the openings of the ureters and the entrance to the urethra. The urethra leaves the apex of the trigone at the most inferior point of the urinary bladder. This is basically at the neck of the bladder. The neck of the urinary bladder is the region surrounding the urethral opening. It contains a muscular internal urethral sphincter, which is composed of smooth muscle fibers that provide involuntary control of urine discharge that we will discuss further in a moment. Urination is also known as micturition, voiding, and elimination. The wall of the urinary bladder contains mucosa, submucosa, and muscularis layers. The muscularis layer consists of the detrusor muscle, which is the main contractile muscle of the urinary bladder. Nerve centers for the control of urination are located in the spinal cord, the brainstem, and the cerebral cortex. Both involuntary and voluntary muscles are involved in micturition. Voiding of the bladder is influenced by the volume of urine that it contains. When 100 to 150 milliliters of urine accumulate, the first sensations of a need to void are felt. The feeling increases in intensity as more urine accumulates, and it becomes uncomfortable at a bladder volume of 350 to 400 milliliters. When the bladder is storing urine, the internal sphincter is tonically contracted by the sympathetic nervous system, the SNS, to keep that sphincter closed and hold the urine in. At the same time, the detrusor muscle is relaxed by the SNS to expand the walls of the bladder to hold a large volume of urine. During micturition, when we want to expel the urine, the PNS, or the parasympathetic nervous system, comes into play. Think PNS for P. The parasympathetic nervous system will cause the detrusor muscle, the main contractile muscle of the urinary bladder, to contract. The PNS will also cause the internal urethral sphincter to relax. These two actions from the PNS, in conjunction with the voluntary or somatic action on the external urethral sphincter, will together allow the urine to pass from the bladder into the urethra and exit the body. The urethra extends from the neck of the urinary bladder and is lined with a mucous membrane, which is called the urothelium. We have previously examined the course of the male urethra, which is on a winding path for about 20 centimeters. It enjoins with the male reproductive system during this course at the prostate gland. But let us further examine the urethra in the female. On this slide, we have a picture of the female urethra piercing the muscular pelvic floor. In females, the urethra lies directly behind the pubic symphysis and is anterior to the vagina as it passes through the muscular floor of the pelvis. It extends down and forward from the bladder for a distance of about 3 centimeters, and it ends at the external urinary meatus. Some of the muscles of the pelvic floor act as an external urethral sphincter in the female. Let's now re-examine the Micturition reflex just because it is so highly tested. In the storage phase, where you are trying to retain or hold onto urine, this is largely controlled by the sympathetic nervous system. The sympathetic nervous system will fire and relax the bladder wall or the detrusor, which is the primary contractile muscle of the bladder. At the same time, the sympathetic nervous system will also contract the internal sphincter, which works to hold the urine in. So you can see how a contracted sphincter with a relaxed bladder wall will allow you to retain or hold the urine. During the urination phase, when you want to expel the urine, this is primarily operated by the PNS, the parasympathetic nervous system. At this time, when the parasympathetic nervous system fires, it causes a contraction of the detrusor or the bladder wall. The PNS also relaxes the internal sphincter, and the PNS works in conjunction here with the external sphincter, which is under voluntary control. So therefore, we have two relaxed or open sphincters and a contracting bladder wall so that urine can be ejected from the bladder through the urethra to the outside world. Voluntary restraint of urination involves inhibition of bladder contraction and closure of the opening to the urethra. Infants' lack of inhibitory control over urination is related to the immaturity of their nervous system. Their corticospinal connections are not well established. However, by the age of 5, 90% of children will have volitional control of voiding. Likewise, degeneration or destruction of certain areas of the central nervous system will lead to incontinence due to a neurogenic bladder. Such incontinence may be a dribbling overflow from a permanently distended bladder, or it could be efflux from a contracted bladder whose outlet is always open. You can also have incontinence that is due to trauma to the internal or external urethral sphincter. If the sphincter muscles lose tone, that can lead to incontinence. Control of micturition can also be lost due to other CNS problems such as a stroke or Alzheimer's disease. Let's now move on to our practice questions. Okay, we'll examine some practice questions now. The urinary system does all of the following except excreting albumin, regulating blood volume, contributing to stabilizing blood pH, eliminating organic waste products, or regulating the plasma concentration of electrolytes. And I hope you select the right answer, which is the urinary system does not lead to excretion of excess albumin molecules. Albumin helps you hang on to your blood volume. The prominent indentation on the medial surface of the kidney is which of the following? The calyx, the pelvis, the ureter, the hilum, or the pyramid? Hopefully you knew that the indentation on the medial surface of the kidney is the hilum. The outermost layer of the kidney is the renal cortex, the medulla, the calyx, the capsule, or the renal pelvis. You had to be a little careful here because you might have wanted to choose the cortex, but remember the cortex is encased in the fibrous capsule, so that is the outermost layer of the kidney. Triangular or conical structures located in the renal medulla are called pyramids, columns, pelvises, nephrons, or calyces. And obviously, a triangle is going to be the pyramid. Here's a little bit more difficult question. You might want to pause so that you can stop and think for yourself how to put the following arteries in proper order of blood flow coming off of the aorta. Okay, let's get to that. The blood flow from the aorta goes into the renal artery, which then divides into the segmental artery as it enters the hilum. These then divide into lobar arteries, which will move up alongside the renal pyramids, and as it arcs over the pyramids into the cortex, become the arcuate arteries. The arcuate arteries then extend as the cortical radiate arteries, or the interlobular arteries, into the cortex. And here, these will give rise to the afferent arterioles that go into the nephron. Urine is excreted from each kidney through the kidney, urethra, papilla, ureter, nephron, or trigon. The answer is urine is excreted from each kidney through the kidney ureter. I hope you didn't pick urethra, though I could understand why you would. Urine's excreted from each kidney through the ureter. It's excreted from the bladder through the urethra. The hilum is the entrance to a cavity in the kidney that is called the renal papilla, sinus, meatus, or foramen. And the answer is, of course, the sinus. The area of the kidney parenchyma, the inner area, of the kidney parenchyma is called the medulla. The kidney parenchyma is the cortex and the medulla, and the inner part is the medulla. What is the arrow pointing to on this kidney lobe? Is it the capsule, the cortex, the medulla, the sinus, or the perinephric fat? and the arrow is pointing to the cortex of the kidney. During the Micturition reflex, are the stretch receptors stimulated in the bladder wall, sending SNS impulses directly to the cerebral cortex? Are parasympathetic motor neurons that control the external sphincter becoming active? Or is the internal sphincter relaxation mediated by the PNS? Or is the external sphincter subconsciously relaxed? Or are all of these correct? Hopefully you knew that internal sphincter relaxation is mediated by the PNS. Remember, PNS for P. The external sphincter is consciously relaxed through the voluntary system. Stimulation of stretch receptors in the bladder wall is not going to send SNS impulses directly to the cerebral cortex. And parasympathetic motor neurons do not control the external sphincter. Again, that's under voluntary control. Okay, that's it. I hope you've learned something. We'll come back and examine the nephron and the formation of urine next time.